Just walk in, I make you smile. It's cool, but you don't even know me. You take it, I run a mile. Can't win, you're always right behind me. And we know that you could go and find some other. Take or leave it, or just don't even bother. Caught in a craze, is just a phase, or will this be around forever? Don't you know it's going too fast? Racing so hard, you know it won't last. Don't you know? Why can't you say slow it down? Leave the sign, say you know just where you're going. Stop right now, thank you very much. I need somebody with a human touch. Hey you, always on the run. Gotta slow it down, baby, gotta have some fun.
All right, good evening, everyone, and welcome to a webinar from the California Emergency Nurses Association. And tonight we're going to be talking about COVID-19, ARDS, and mechanical ventilation for the ED nurse. So my name's Tobin Miller, and myself, along with Jen Deno, will be leading you through this webinar tonight. Before we get started, though, just a little disclaimer here. This presentation is intended to provide you with an overview of COVID-19, ARDS, and mechanical ventilation for ED nurses. Each situation, though, is going to be unique, and the authors in California ENA cannot assume responsibility for any actions that you take based on the information given during tonight's presentation. We've made every attempt to ensure the accuracy of the information in the lecture, but as always, follow your own policies and procedures. So now that that is out of the way, just gonna go over our agenda tonight. We're gonna start with going over a little bit of the basics of ARDS, since that's really what we're seeing in these patients. Then we'll talk about mechanical ventilation. We're gonna talk about mechanical ventilation from the standpoint of taking care of a patient on a ventilator where we may have to manage that ventilator ourselves. So where we may have to actually make changes to those vent settings or put someone initially on a ventilator, maybe without the assistance of a respiratory therapist. Then Jen's going to talk about COVID-19 and bring us through a case study about COVID-19. And at the end, I'll go over the CEU process because you will be eligible for 2 contact hours of continuing education today. At the end of the presentation, I'll go over how to actually access and get that continuing education. And then time permitting, we will do a question and answer period at the end of tonight's presentation. So before we get started here, I'd like to introduce Jen. You should be able to.
Hi, everyone.
So
we're glad to see you all tonight.
All right, and thank you for joining me, Jen. It's been great to collaborate on this and great for us to be able to bring this to emergency nurses and any other nurses that are with us tonight because we know this is a hot topic right now, not knowing really what's in our future soon just with the evolving pandemic that we're under right now. So thank you everyone for being here, and thanks Jen for collaborating on this.
Yep, I'm gonna close my video so you can talk.
All right. All right, so our objectives that we're going to go through today. So we're going to talk about common modes and settings of mechanical ventilators, some of the different alarms that we'll see, care plan changes that we'll need when we're dealing with mechanically ventilated patients, and then the pathophysiology of ARDS, some of the common treatment approach that we're going to do towards ARDS, and then identify symptoms and treatment for COVID-19 specifically. So an important thing to remember when we're talking about COVID-19 is it's not the COVID-19 that's actually killing people. It's the sequelae from that. It's the ARDS that they're getting when they have COVID-19. So let's start by talking about ARDS. So ARDS in general has a variety of causes, and they can be direct or indirect causes. So we can have a direct injury. So that would be something like a near drowning patient or somebody that has a pulmonary embolus or a fat embolus or an amniotic fluid embolus, inhalation injuries, pulmonary contusions after trauma. So those are direct injuries to the lungs, which then can lead us down an ARDS pathway later. We can also have indirect injury leading us down an ARDS pathway. So that would be trauma in a different part of our body, or somebody that's septic, they have prolonged hypotension, maybe an overdose patient, head injuries, or pancreatitis. So when we look at what ARDS is, that's where COVID-19 would fall, is it's an indirect cause of ARDS. We don't have a direct injury that we're having to our lungs. So generally, what is ARDS? So ARDS is an inflammatory response. So what happens is we have that inflammatory response. So think about your SIRS criteria. So we have that inflammatory response, and when we have that, we have mediators that are produced. So those mediators go to the site of the injury if there is an injury, but they also float around in our bloodstream. And when they do that, they affect our alveoli. So the epithelium on the alveoli and the capillary, and I apologize, I'm Canadian, so some words, sometimes it comes out capillary and sometimes it comes out capillary because I get mixed up with it from the Canadian pronunciation or the American one. So those epithelium are damaged. And when that happens, fluid is able to leak through there. So the alveoli get flooded with fluid because it's shifting from the capillaries into the alveolar sac, so into that alveolar space and into the space between there. So when that happens, we get that fluid filling in there. We also, at the same time that that's happening, the cells that produce surfactant in our lungs are damaged. So that means we have a decrease in the amount of surfactant. And what that surfactant does is it helps those alveoli when they're opening to kind of reduce the surface tension on them. So those alveoli then have trouble staying expanded. So those alveoli continue to be filled with fluid, and that fluid that ends up in there, that's leaked in there, is protein rich. And what happens when you have protein rich fluid? It's going to pull in more fluid, right? So it's going to make the problem worse and worse. And when that happens, when we have these alveoli that are filled with fluid and are having trouble staying expanded, then oxygenation can occur. And that's really what happens in ARDS is we get these just profoundly hypoxic patients that we just can't seem to get their hypoxia corrected. It's very difficult to correct that hypoxia. So we can't effectively oxygenate these patients. So that's really what ARDS is as far as the beginning of ARDS. Now we can go down this ARDS pathway and talk about what happens, 2 weeks later and that sort of thing where there's even more problems, but I'm looking at it from what you're going to see kind of initially. So the initial processes that are happening is we have that inflammatory response. Mediators are going through the bloodstream. They're going to affect that epithelium, which is going to let fluid leak into the alveoli. We're also going to decrease our surfactant production there because we're damaging those cells, okay? So it's just going to then become just hard to oxygenate these patients. So if we look at it a little more broadly than that, so what is ARDS? It's just a group of manifestations of an evolving severe diffuse lung injury. So it's an evolving injury to your lungs because there's all those different components happening. So it's just kind of getting worse and worse, and it's getting harder to oxygenate these patients. And when we're seeing it as a result of COVID-19, we're seeing these patients going downhill fairly fast a lot of the time. So the diffuse inflammatory lung injury leads to that increased pulmonary vascular permeability, and then we end up with this hypoxia. So later on in the course of ARDS, some patients end up getting an irreversible fibrotic stage where they have collagen that deposits in their alveolar, vascular, and interstitial beds, and then they develop microcysts. And that's when you hear about that kind of honeycombing in the lung. That's what's happening there. And Jen will talk more kind of about the critical care piece of this and what happens later on in these patients as far as ARDS go. So how would we know that a patient's in ARDS? If we have this patient presenting in the emergency department, how could we define ARDS? And there's different ways to do it, but we'll look at the Berlin definition right now. So in the Berlin definition, this is happening within a week of the incident. So for us, there isn't really an incident other than they are COVID-19 positive if we were talking about a COVID patient, right? If we were talking about somebody that had a pulmonary contusion, say, that led down an ARDS pathway, it's within the week of that trauma event. So these patients, they would have an unexplained opacities on their chest x-ray. So on imaging, we see that, and we don't have another way to explain why that's there. So it's not because they have CHF, because they have a cardiac issue going on, or they're fluid overloaded. So we don't have another way that we can define what's happening for them. So they just have these opacities. We don't have another cause for them. And then we can classify it if we're going to look and say, how severe is this ARDS in the patient? Is according to the Berlin criteria, we would look at how their FiO2 and PaO2 are. So we take what's called a PaO2 FiO2 ratio. So we look at the ratio of their arterial oxygenation compared to their FiO2, so the amount of oxygen we're giving them. And when you look at this criteria, it's taking into consideration that they're on 5 a PEEP. That's just the underlying criteria for it. So if we were to say someone had mild, moderate, or severe ARDS, we just look at what the ratio is. And if the ratio is 2 to 300, we would call it mild, 100 to 200, moderate, and less than 100, we'd call it severe. So how do you get that actual ratio for the PaO2 FiO2 ratio? So I'll show you how we would come up with that number. What we would do is just take our PaO2 and divide it by our FiO2. So all we do is take from the blood gas, our PaO2, and we divide it by what percent oxygen the patient's on. So I have 3 examples on your slide here. So John Doe has a PaO2 of 96. So we draw his gas, he has a PaO2 of 96, and he's on room air. So room air is going to be 21% oxygen, right? So we express it as a fraction, so 0.21. So we take 96 and we divide it by 0.21, and that gives me 457. So John Doe's PaO2 FiO2 ratio is 457. So if we look back at that criteria, he is not falling in any of these ARDS criteria, okay? If we look at Jane Doe, so she has a PaO2 of 90 and she's on 35% FiO2. So arterial blood gas gives me a PaO2 of 90. We're going to divide that by 0.35 for 35% FiO2, and it gives me 257. So in Jane Doe, if we look back at this criteria, she would be considered mild ARDS because her PaO2 FiO2 ratio is between 2 and 300. And she has all the other criteria. So she has those opacities that we can't say there's another reason for. She's not fluid overloaded, she's not in CHF, she doesn't have failure, that sort of thing. And she's on 5 a PEEP, and these are our numbers, then that's what we would say. She would be a mild ARDS patient. The last example there, Sally Doe has a PaO2 of 85, and she's on 90% FiO2. So a PaO2 of 85, and we divide that by 0.9 for the 90% FiO2, and that would give us a number of 94. So if we look back at that criteria, she would be down here in the severe ARDS because that PaO2 FiO2 ratio is less than 100. So that's going to be a severe ARDS patient. So what's recommended as far as taking care of COVID-19 patients that have ARDS? So if we take the recommendations from the World Health Organization, the first recommendation that they had was to recognize severe hypoxemic respiratory failure, failing standard therapy, and prepare to provide advanced support. So what do they mean by that? What they're saying here is if we have a patient that has hypoxemic respiratory failure, so these are the patients that come in and they're in respiratory failure and we're going to try some initial interventions. Let's say we're trying a nasal cannula on them and their oxygenation is not improving. We're trying a non-rebreather on them, their oxygenation is not really improving. We want to already be thinking down that pathway that they're probably going to need advanced support. So it's recognizing that process that they're under very likely will need advanced support, and then we're going to end up down a pathway to intubate these patients. Their next recommendation was that endotracheal intubation is done with airborne precautions. There's been a lot of controversy recently about the level of precautions for these patients, but they have stipulated that for endotracheal intubation, because that is an aerosolizing procedure, definitely want airborne precautions for that. Their next recommendation was that mechanical ventilation with lower tidal volumes, so 4 to 8 milliliters per kilogram of ideal body weight. This is something that's very common when we're dealing with ARDS patients. So we're doing what's called lung protective ventilation strategies. Those lungs in the patient that has ARDS, those are sick, hurting lungs. Those alveoli are not doing well because remember, they're filling with fluid, they're losing surfactant production. So we don't want to hurt those lungs even more. We don't want to hurt those sensitive alveoli even more. If we start blasting them with big tidal volumes, we can actually cause barotrauma and hurt those sensitive alveoli. So that's why we use lower tidal volumes. We're doing lung protective ventilation. And when they say 4 to 8 milliliters per kilogram of ideal body weight, that means we need to look at what is this patient's ideal body weight, not what their actual body weight is. Because the thing to keep in mind is a 400-pound patient that's 6 feet tall has the same size lungs as a 200-pound patient that's 6 feet tall. Our lungs get bigger when we get taller. The bigger around we are, our lungs aren't getting any bigger. There's just more stuff sitting on top of them, making them harder to ventilate. So we're going to use lower tidal volumes, and we'll look at an ideal body weight chart in a few minutes. And after the course, when we send you your continuing education certificate, with that, there's some documents that we'll be sending out. And one of them is a nice chart that shows you ideal body weight and then the mils per kilo. And I'll show you that in a few minutes. It's on another slide. The next recommendation from the World Health Organization was to keep plateau pressures less than 30. And what a plateau pressure is, and we'll talk about what they are later, but what they really are is the pressure that's actually kind of hitting those alveoli when the patient has their lungs inflated. So on inspiration, what's the pressure that's actually hitting the alveoli? So we'll talk about how to get to that in a few minutes. Uh, Prone ventilation is the next recommendation. So prone ventilation for 12 to 16 hours per day. So that's where we actually take the patient and we have them face down on their stomach when we're ventilating them. So that's something that's fairly common in ARDS patients. Keep in mind, this is normally done in an intensive care unit where we have specialized equipment, specialized beds for this. We put them on a rotaprone bed and it would rotate them, onto their face down position, and they would be pronated, 12 to 16 hours a day. Well, we don't have that option in an emergency department typically. So we have to start thinking, and Jen will talk about this later on when she talks about management of these patients, but manually proning these patients, and what's that going to look like in an emergency department? How are we going to accomplish that? And what do we have to think about as far as, padding different prominences when we have somebody face down that we're ventilating? And how do we do it safely without pulling out lines and tubes? Their next recommendation is conservative fluid management if there's no tissue hypoperfusion. So if they're not having tissue hypoperfusion, we don't want to blast them with IV fluids. And the reason for that is if we're giving them a lot of fluid, we don't want to have more of a leak, because remember, we've already had that leak causing fluid into their alveoli. Their next recommendation was to consider higher PEEP for moderate or severe cases. This again is something that's pretty common in an ARDS patient, is to increase their PEEP. And what our PEEP is our positive end expiratory pressure. So that's at the end of exhalation, and we'll talk about this also in a few minutes, the amount of pressure that we keep in their lungs, because that's going to help keep those alveoli open, to keep that surface for gas exchange there, so that gas exchange can happen. So higher levels of PEEP are needed in these patients quite commonly. We'll talk again more about that in a few minutes. Next recommendation was that patients that are treated with high flow nasal oxygenation or non-invasive ventilation should be closely monitored for deterioration. Well, this one in a lot of facilities is kind of a moot point, because we're not typically jumping onto high flow nasal cannula or BiPAP on these patients that we suspect are COVID-19 patients, because those procedures cause aerosolization. So just in the interest of infection control, these are often being skipped and moving right to intubation. Their last recommendation on here was to consider ECMO referral for refractory hypoxemia despite lung protective ventilation. And that's something that's going to be very dependent on the facility that you're at. Not every facility has an ECMO program or has the referral capabilities for ECMO. And in the face of a pandemic, we're not going to be able to put every patient on ECMO. We're not going to be able to put a majority of patients on ECMO, because we just don't have that ability to have that many ECMO machines, ECMO circuits, and ECMO trained staff at facilities to do that. So that's kind of the basics of what ARDS is. And we'll talk more about ARDS a little bit later when Jen talks about management of the COVID-19 patient. What we're going to do now, though, is jump into going over the basics of mechanical ventilation. So before we start talking about mechanical ventilation, we want to talk about how we're ventilating now when we're just sitting here. So when I'm just sitting here right now, I'm negative pressure ventilating. What I mean by that is when I go to inhale, my chest wall is going to expand. My diaphragm's going to lower down. That's going to increase the space in my chest. That's increasing that space in my thoracic cavity. When I do that, there's less pressure in my chest than there is in the atmosphere around me. So that pressure gradient just causes air from the atmosphere to passively move into my body. When it's time to exhale, the exact opposite happens. My chest wall is going to relax and recoil. My diaphragm is going to pop up. That space in my thoracic cavity is going to shrink down. So when that happens, I have more pressure now inside of my body here. And what's going to happen is that air is going to passively then move out into the atmosphere on that same negative pressure gradient. Whenever we take over ventilating for somebody, we take away this entire mechanism that I just explained to you. We take away negative pressure ventilation, because what we do is we seal off their airway completely. We seal it off with a endotracheal tube or with a supraglottic airway, a King airway, or a tight seal on a face mask, like a Ambibag mask. Whatever method we use, we're sealing off their airway system and we're forcing air in under pressure. So we're positive pressure ventilating them. So whenever we positive pressure ventilate someone, remember that's always going to come with risks. We're forcing air into a patient instead of letting it go passively into a patient. So we always have those inherent risks when we do that, things like causing a pneumothorax, we're forcing the air into the patient. We can also be causing damage to their lungs. And when we talk more about ventilation in a minute, high pressures, high volumes causing damage to those sensitive alveoli. So who needs mechanical ventilation at kind of a generalized level? Patients that have respiratory failure, patients that have a respiratory arrest, airway protection, and gas exchange problems. So we'll look at each of those independently. So indications for mechanical ventilation for respiratory failure, these are typically those, increased work of breathing patients. They're getting tired, maybe they're not responding to initial interventions. If this isn't a suspected COVID patient, we may have somebody on BiPAP and they're failing at BiPAP, so we're going to move down that pathway to intubation. Or it could be somebody that has an absence of a respiratory effort, and that, remember, could be a medical or a trauma cause. So that would be a respiratory failure patient. Next would be for airway protection. So we could do this before a procedure for a patient to protect their airway, so that if they were to vomit during the procedure, they wouldn't aspirate. If a patient has an altered level of consciousness, they don't have a gag reflex, then we're going to just have them intubated and mechanically ventilated for airway protection purposes. And lastly would be gas exchange problems. So a patient that has significantly, abnormal ABGs, maybe their ABGs aren't improving with initial interventions, and we'd want to think about, is this a ventilation issue or is this a perfusion issue? Is this both? Because it could be one, the other, or both. So common modes and settings as far as mechanical ventilation. So at a real basic level, we're going to have either pressure or volume. Those are the two ways that we can ventilate a patient. And then we can have the patient controlling the ventilation, or we're controlling the ventilation. So it's either going to be patient controlled or not patient controlled. And lastly is PEEP. So the amount of positive and expiratory pressure that we have applied to the patient. So pressure or volume, patient controlled or not patient controlled, and then PEEP. So we're going to explore each of those. So first is volume versus pressure ventilation. So on the left side here, we're going to talk about volume controlled ventilation. So someone that's in volume controlled ventilation, they're going to have gas delivered until a preset volume is attained. And when I say gas delivered, I'm simply talking about whatever we're ventilating the patient with. If that's room air, it's 21% oxygen. If it's 100% FiO2, 100% oxygen, or anything in between. So whatever that gas mixture is, we're going to deliver that gas mixture to the patient until we get a certain volume. That volume that we give the patient is going to be delivered regardless of how much pressure it takes to do that. Now, within reason, there's a limit, there's alarm limits and stuff that it wouldn't let you, blow up a patient, but it's going to use whatever pressure is necessary to get that volume in. So this would be someone where we said, give them 12 breaths a minute, 500 cc's of breath. Every breath is going to be 500 cc's, no matter how much pressure it takes. So typically the volume that we're going to talk about, in most patients, we'd look at, 6 to 8 mils per kilogram of their ideal body weight. In ARDS patients, so like these COVID-19 patients that are getting ARDS, they're looking at a little bit lower tidal volumes than that, even 4 to 8 milliliters of their ideal body weight. So that's volume ventilation. We can then look at pressure controlled ventilation. So in pressure modes of ventilation, the gas is going to be delivered until we get a certain airway pressure. So the volume that we give them is going to vary. It's going to vary from person to person. It's going to vary from breath to breath. So in pressure modes of ventilation, what happens is, remember, we have the airway sealed off, and now we're going to inflate with pressure. So it's going to put air into the patient until we get a certain pressure in the airway. So let's say 22 of pressure. It's going to inflate. We get 22 of pressure. It's going to hold it there for a second, and then it's going to release. If you give me 22 of pressure sitting right here, you might get back 500 cc's of air. If we give Jen 22 of pressure, you might get back 400 cc's of air. If you then lay me on the ground and give me 22 of pressure, you might only get 300 cc's of air because you have the weight of my chest now on my lungs. So you're going to get various volumes from person to person, and from breath to breath can be different. So the risk of pressure modes of ventilation is we don't necessarily have a controlled tidal volume, a controlled minute ventilation on the patient as easily as we do with volume ventilation. But the benefit of pressure ventilation, and a reason that we see pressure ventilation used a lot in sick lung patients, like ARDS patients, is it helps avoid barotrauma in the lungs because we're controlling the amount of pressure that we're applying to those lungs. So if we're setting the limit of pressure, then we know we're not going to cause excessive damage to those alveoli because we're controlling the amount of pressure on them. So when we look at ideal body weight, when we're talking about that, this is just a graph to help you determine what their ideal body weight is for a patient. So if we were to use this example and go over here and we see a patient that's 6'2" tall, that's male, and we wanted 6 cc's per kilogram, we would go over here and it would be 490 cc's per breath. So this is just a handy chart that you can use if you do have to set someone up on a ventilator in a hurry to look at their ideal body weight and then see what that ideal body weight is. And it gives you a little cheat sheet on here as far as how many mils per kilo that works out to. So when we do send out the post-course CE certificates later this week, a copy of this ideal body weight chart is in a sample vent protocol that will be sent out for you. So you can have that and keep that in your back pocket in case you need it. So along with either using volume or pressure, the ventilator needs to know when to trigger a breath. When should it be giving the patient one of these breaths? So that's where we look at the different ventilator modes. So the first mode we're going to talk about is CMV, so controlled mandatory ventilation. Rarely used anymore in patients that have any sort of respiratory drive themselves. And the reason behind that is it's going to deliver a certain number of breaths to whatever the settings are, regardless of what the patient's doing. If we have a patient on controlled mandatory ventilation and they are set to have 12 breaths a minute, 500 cc's of breath, that patient is going to get 12 breaths a minute, 500 cc's of breath. Even if they're running down the hallway and the ventilator's being pulled behind them, they're getting 12 breaths a minute, 500 cc's of breath. It doesn't care what the patient's doing. So that's why we see assist control instead. So in assist control, what's happening is it's going to still deliver those set number of breaths to the patient. So if we said 12 breaths a minute, 500 cc's of breath, they would get that. But if they want to have an additional breath, it's going to let them. So if they try and take another breath, they're going to get that other breath. Whereas in CMV, they're going to be fighting against the ventilator. So in assist control, they would be allowed to have the breath. Very common mode for respiratory failure patients. We see it a lot in emergency department. It's going to deliver that set number of breaths to whatever that setting is. So if it was 12 and 500, they're going to get 12 breaths, 500 cc's. If we were in pressure ventilation, so say pressure control with assist control, pressure of 20, they would get however many breaths with 20 of pressure for each breath. The breaths that they take on their own are allowed to count into that number of breaths they take that minute if they fall at the right time. What I mean by that is every breath is allotted a certain amount of time. It's called a breath cycle. So if I was breathing 10 times a minute, so I set a ventilator to breathe 10 breaths a minute, well, there's 60 seconds in a minute, right? So that means every breath cycle is 6 seconds long. So if this patient triggers an additional breath and they're at about second 5 in their breath cycle, well, that's going to fall into the next breath cycle. So that breath would count as one of their breaths for that minute. But if they take a bunch of extra breaths, it's going to be giving them extra breaths then above and beyond those 10 breaths that we had set the ventilator for. So with that, there's a little bit of risk sometimes because that means every breath that they ask for is a fully assisted breath. So that's the trick with assist control, is every breath is fully assisted, meaning every breath, if you're set to 500 cc's per breath, is going to be 500 cc's. So if they take 10 extra breaths on top of the 10 that they were already getting, that means they would get 20 breaths of 500 cc's each. And we don't necessarily want that on a patient whose blood gases are a bit finicky, because that means they're going to be blowing off a lot more CO2. Their minute ventilation is going to be twice as much as what we had the ventilator set at. So that's a risk with assist control ventilation. The other risk is if I'm taking extra little breaths and I'm getting full big breaths from the ventilator, I have the risk of stacking those breaths on top of each other and creating excess pressure in my thoracic cavity. So that's assist control ventilation. The other one that we see a lot of is SIMV. So that's synchronized intermittent mandatory or mechanical ventilation. And what that does is just like assist control did, it's going to deliver however many breaths we said, but the patient's breaths will count just like they did in assist control. If they fall at the right time, they're going to count towards that breath count for the minute. But the important thing with these is if the patient triggers excess breaths on top of the number they need for that minute, they're not necessarily going to be full breaths. So if the patient's just, laying in the bed and wants to take just a little sigh of a breath, they can do that. As opposed to taking that little tiny breath and getting blasted with a complete 500 cc breath or whatever their ventilator settings are. That's what would happen in assist control. In SIMV, they can take that little extra little breath. In order to do that, there's something called pressure support. So you'll very often see SIMV, and there'll be an extra number, which they call the PS, or the pressure support. That does not mean that they're in a pressure mode of ventilation. All that that means is there's a little pressure to help when they want to take an extra breath so that they don't feel like they're suffocating. Because think if you're laying there in that hospital bed and you're hooked up to a ventilator and you have this long ventilator circuit going to your vent, and you try and take an excess little breath, you have to suck the entire length of that ventilator tubing. You might feel like you're kind of suffocating and air hungry if you try to do that. What pressure support does is it just kind of puts a little punch behind that. So it gives that little bit of pressure, so typically 10 of pressure support, that when the patient goes to breathe in, if they want to just take that little breath, there's about 10 of pressure sitting behind it so that they don't feel like they're having to breathe that entire dead space of the ventilator circuit. You can think of that kind of like a patient that's on BiPAP and they take a breath in and they're supported. That's what pressure support does for them. So SIMV with pressure support. The last mode I'll talk about on this slide is going to be just pressure support ventilation, not something you're really going to see much of in an emergency department. This is the patient's going to control their own rate and tidal volume. This is something we use more if we're going to be taking somebody off of a ventilator. So they've recovered in the ICU, we're getting ready to extubate them. We want to see how they can do on their own. So we might do pressure support ventilation for a little bit. So it gives them pressure on the way in and leaves pressure on the way out. But they're going to breathe on their own and take however big a breaths in whatever rate they want. So this is basically BiPAP with an endotracheal tube is what it is. So we're not going to do a lot of that, especially for an ARDS patient in the early stages. So the two modes that you're really going to see a lot of in an emergency department, or you might have to set up in an emergency department on a vent, would be assist control or SIMV. To give you an idea of what those kind of look like, if you're a kind of a visual learner and want to see, this first graph is going to be just CMV, controlled mandatory ventilation. So these waveforms are just the breath for the patient. So you can see we have a breath go in, the end of my breath period or breath cycle, then we have our next breath, then we have our next breath. They're very evenly spaced. It's just giving however many breaths a minute we said. The next one on here is going to be assist control. So if we looked at this, they have a breath, then it's time for the next breath. So they take that breath, and then you'll see this dip below the line. That's the patient making a respiratory effort. That's the patient taking a little inhalation. When they tried to take that inhalation, they're given a breath. So what happens is the machine sensed that, it gave them a full breath because in assist control, they get that fully assisted breath. You can see that it fell into the next breath period, so it counts as one of their breaths for that minute. Then they hit their next breath cycle, so they got another machine breath given to them, even though they didn't try and inhale for that one. So that's assist control. This next graph that we're going to look at is SIMV. So this is what SIMV would look like. So the machine gives them a breath, then it went along, it was time for another one, so the machine gave them a breath, then they tried to take a breath. When they tried to take a breath, the machine kicked in and gave them that fully assisted breath. But then they said they wanted another one. Well, it's not time yet for another one. So the machine just gave them, you'll see it here, a little bit of pressure support. And that pressure support allowed them to not feel like they were suffocating. But you can see they didn't take a full breath here. They just took a little supported breath. Then they tried to take another breath here. It's into a new breath cycle, so it gave them that full breath. Then they took a couple extra little ones here. They were just supported with pressure support. Then they took another one. They got a fully assisted breath. You can see down here, the next breath cycle, they didn't trigger a breath, but it didn't give them one because they're already one ahead for the minute from back here. But then they still didn't take one at the end of that breath cycle, so the machine kicked on and gave them a breath. So if you think about it, a patient on SIMV, if they're a little more alert, a little less sedated, this is a nicer mode of ventilation potentially for them, because if they try and breathe on their own and take little breaths, they're going to feel supported to do so, but they're not going to get blasted with an entire big breath for doing that, like they would in assist control. And it's going to try and synchronize with the patient's respiratory pattern a little bit better, as you can see in this graph. So this is potentially going to be a little bit more comfortable for a patient that's either less sedated or more alert a little bit. This last graph is just to show you, if the patient didn't trigger a breath for a period of time, the machine's always going to kick on and give them a breath because there's an apnea period built in. So those are kind of the four main modes that we'll look at, the four basic modes of ventilation. Now we're going to look at two more modes of ventilation. These are two modes that you are not going to be able to set up on a non-big ICU ventilator, basically. The reason I'm going over these as kind of separate items is, in the face of a pandemic, you might not have big critical care multimodality ventilators at your disposal, right? So the four modes that I went over are going to be pretty typical to be able to do on most ventilators. These next two are a little less common for like a transport ventilator or the ventilators that we actually have in the national stockpile from the government that they can issue out to hospitals. So this first one we're going to talk about is pressure regulated volume control. So you would see this up in the ICU. What happens in pressure regulated volume control is it's a combination of pressure and volume. So what it does is it lets us get a certain volume through the patient every minute. So if we had a patient that was on volume ventilation and they were set at 12 breaths a minute, 600 cc, 500 cc's a breath, we know that if they don't take any extra breaths, they would be breathing 6 liters a minute, because 12 times 500 would give me 6,000, so 6 liters a minute. So if I had somebody in volume ventilation, I know how much volume I'm putting through them in a minute, which is important when we're looking at gases. But we don't necessarily want volume ventilation sometimes if we're trying to protect those sensitive alveoli, right? Because we're trying for lung protective ventilation strategies, so to have less pressure on those alveoli. So PRVC will do this for us. So what it does is you tell it the volume that you're going for. So I could say I want 12 breaths a minute, 500 cc's a breath. I want that 6 liters through the patient in a minute. And what it would do is it would deliver a volume breath. So it's going to deliver a 500 cc volume breath. And it's going to see how much pressure did it take to deliver that breath. And let's say it took 23 of pressure. Then the next breath, it's going to deliver a pressure breath. And it's going to deliver 23 of pressure. And it's going to see how much volume was it. And if it's around that 500 cc mark that we had set, it's going to say, good, I'm going to keep going with this and give another breath at 23 of pressure. But then if it says, oh, that was only 400 cc's, we need more pressure, it's going to increase its pressure. So the next breath, maybe it'll do 25 of pressure and see how much volume it gets. So it's going to do this all automatically in the background. It will adjust up and down as it needs to, and it will adjust the pressure needed. And the benefit and what this mode really is doing for us is it's delivering the volume that we want. So we get that kind of guaranteed minute ventilation, so we can really kind of keep their gases in check a little bit better. But we're going to deliver that volume at the lowest possible pressure to help protect those sensitive alveoli. So this is another lung protective kind of mode of ventilation. As far as the other stuff I have on this slide about the settings, basically the basics of what you need to know with it is it's not going to increase the pressure on most ventilator models within 5 of your high pressure alarm limit. So if I had a high pressure alarm limit on my ventilator set at 30, and the breaths that it's giving is taking 23 of pressure, and then it needs to increase it, it's going to alarm out when it hits 25, because that would be within 5 of my alarm limit. It's just something to keep in mind. It might start alarming because of that. And it's never going to change it drastically. It's not going to say this breath was 15 of pressure and then it gets back a little breath, oh, let's go 30 of pressure. No, it's never going to move by more than 3 typically on most ventilator models. It'll move by either 1, 2, or 3 centimeters of water of pressure. If something weird is sensed by the ventilator, meaning there's a big alarm, like it gets back a really low tidal volume or a really big tidal volume, or there's a high pressure alarm on the vent, any, alarms that go off, any changes that you make to the ventilator settings, it's always going to redo that test breath. So it'll redeliver a test breath in volume, see how much pressure it took, and then it will start delivering pressure breaths again. So if we wanted to kind of look at this for our visual learners, if we look at the first one, it's going to be a volume breath. And on a ventilator waveform, the volume breaths are kind of a little more shark finny. So it's this volume breath here, and it sees how much pressure it took to do it. I'm going to see if I can draw a fancy line on the screen. We're going to try this. All right. So this was where the volume breath was over here. So then the next breath is a pressure breath. You can tell it's a pressure breath because it kind of comes up, stays up, and then falls down. So this pressure breath went to whatever amount of pressure it was that the volume took on the first breath. And then it will adjust the pressure. So you can see this one is a little bit lower, and it got back the right amount of volume. So then this next one, same. The next one, about the right amount of volume, same. Then it says, oh, I got back a low volume. So I'm going to give a bigger amount of pressure to give a bigger breath. So you can see it's adjusting itself as it goes along. All right, so the last mode that we're going to talk about is a different mode that you'll see this in ARDS patients as well. Again, not a mode that's going to be common on kind of emergency supplied ventilators, transport ventilators, travel ventilators, the smaller ones. You're not going to see APRV typically on them. What APRV is airway pressure release ventilation. So it's beneficial in ARDS, and what it does is it's kind of a reverse type of ventilation. It's continuous high pressure with short releases down. And so it's an inverse ratio of ventilation. So these patients typically are, a little more sedated because it's an inverse ratio. So high pressure releases the pressure down. So that just really helps to keep those alveoli open. So to keep that surface there for gas exchange. Again, not something we're going to have on portable kind of emergency ventilators though. So other values when we're talking about mechanically ventilated patients. So tidal volume, that's simply the volume of air that's going to be delivered per breath. We have two types of tidal volume. Remember, we have tidal volume that we're setting, so our set tidal volume, but we also have something called it, which is just our TV, tidal volume. We also have something called an ETV. So usually that's expressed as a small e and then capital TV. And what that is that's our exhaled tidal volume. So that's a real important thing to know. If we look at a ventilator, especially if somebody's in a pressure mode of ventilation, is we can look and see what are the volumes that we're getting on the patient. Oh, we're getting back, 400 of volume. Okay. And we can look at that to see if it's changing or not. Next thing is our rate. So our rate is simply just the number of breaths per minute. FiO2 is our fraction of inspired oxygen. And remember, depending where you work, this may be expressed as a percentage or it may be expressed as a fraction. A lot of places will say, 50%, 75%, 35%, whatever that FiO2 is, whereas some places are going to say 0.4, 0.8, 0.5, 1.0, whatever. So just know that fraction or percent means the same thing. MV, that's our minute ventilation. So that's the amount of gas delivered in 1 minute. That's a real good number as well to look at on your ventilator screen and see what that is, because that's going to tell you how much is the patient actually breathing. So especially if they're in SIMV, where they can take varied amounts with their extra breaths, I want to look and see how much are they actually breathing. Because if I had my ventilator set, let's do easy math here, 10 breaths a minute, 500 cc's of breath, so 5,000 mils, 5 liters per minute is what I set the ventilator. I can look at their MV on the vent and see that it's 7.2. Well, that means they're breathing 7.2 liters a minute, and I only set the ventilator at 5 liters a minute going through them. So they're over-breathing the vent by about 2.2 liters. Good number to know to see how much is this patient really over-breathing the ventilator. In PEEP, PEEP is going to be our positive end expiratory pressure. So we'll talk about PEEP in just a second. Another value that I talked about rate a second ago, but one thing to always look at on the ventilator as well is how many times did they actually breathe in the last minute. In the ventilator, when you look at the screen, we'll tell you that. It'll usually be a fancy looking small F. That's their breath rate for the minute. And if your breath rate says that they breathe 32 times, but you have the ventilator set at 12, then you know this patient's significantly over breathing that ventilator and taking extra breaths. So let's talk about PEEP. So what does PEEP do? Well, PEEP it helps keep the recruited alveoli open. So this is real important in ARDS patients because we want to keep those alveoli open, because remember, those alveoli are filling with fluid, they've lost some surfactant, we're having trouble oxygenating these patients, they're typically profoundly hypoxic. We really want to keep the PEEP in there to keep those recruited alveoli open, because that's going to give us the surface for gas exchange to take place. Typically, on most patients, non-ARDS, just general patients, when we're throwing them on a vent, we're putting them on 5 a PEEP. That's kind of the standard, everybody gets it for showing up type of setting is 5 a PEEP. And that just is so that when we exhale, there's a little bit of pressure left in the system there to help keep those alveoli open. It can decrease our preload and our afterload. So in general, we would use caution in hypotensive patients, especially if they have right heart failure, some MI patients. PEEPs of 8 to 10, you'll sometimes see those higher 8 to 10 numbers in CHF patients, but in ARDS patients like these, we're going to see even higher numbers a lot of the time. You may see PEEP numbers creeping up to the 16, 18, even 20, depending on the patient in a severe ARDS patient. If they're really having a tough time oxygenating, you're going to see high FiO2s and high PEEP numbers. So we're going to look at this little video now, and you see these lungs right here. So these are lungs that are not inflated right now. And then we're going to start breathing. And you'll see the lungs inflate and deflate here. Inflate, deflate. And now they're going to add PEEP. So we inflate the lungs, but we're leaving 15 a PEEP. So now they deflate, inflate, deflate, inflate, deflate. So now you see how much more surface area we have for gas exchange. And this is by having PEEP, because we're recruiting all the alveoli. We're getting all that surface area for gas exchange to take place. When we release that PEEP, what's going to happen? Those lungs are going to go right back down. So in this example, these are healthy lungs. And you can see in this healthy pair of lungs here, it took what, about 5 breaths to fully recruit those lungs, to fully get all that surface area there for gas exchange to take place. Well, that's not the reality on sick lungs. Sick lungs are going to take a lot longer and be a lot harder to recruit those alveoli. So we're going to need that PEEP on them. We're going to potentially need higher numbers of PEEP, and we're going to need PEEP, for a longer time to get that recruitment. So you're not going to necessarily see it in the first 5 breaths like we saw on here. So we want to do things as well on the real sick ARDS patients. We want to do things to keep the PEEP in the patient. So what I mean by that is, once we've done this, so say their SATs were low, we have them on a high amount of PEEP, and their SATs have been creeping up, what's happening is we probably have been recruiting more and more alveoli. And remember, these alveoli, some are filled with fluid, they're not that healthy, so it's going to take a while. Once we're getting them recruited and our SATs are getting better, we want to keep that PEEP. Because what can happen is, if we disconnect their vent circuit, what's going to happen? All of a sudden, that PEEP's gone. So those lungs are going to go right back down, and we're going to have to spend all that time again re-recruiting those alveoli. So we want to the best of our ability, keep the PEEP in the patient. It's also good considering an infectious patient, because we're going to then keep the system sealed, right? So how do we keep the PEEP in the patient? A couple things. We want to not unnecessarily be disconnecting our ventilator circuit. If we do need to disconnect the ventilator circuit, if this is a real sick ARDS patient that we've had a real trouble recruiting those alveoli, then we may actually clamp the endotracheal tube when we're switching devices. And it's not prolonged clamping or anything. All it is they've exhaled, clamp, pop it off, pop your new device on, unclamp. And all that does is just keeps that PEEP in the patient so that it doesn't all escape out and we have to go through that recruitment again. The other thing that we would be doing is suctioning the patient with a Ballard device. So simply the inline suction device on the patient, instead of the way we used to do things, if you remember, pulling off that, sticking down a suction catheter, going back onto the vent. Again, not something we want to do anyway, because we don't want the aerosolizations if these are infectious patients. So we should always have inline suction anyway. But those are 2 things we can do to make sure we keep the PEEP in the patient. So if someone's kind of throwing vent settings at us, these are just a few examples for you. So if somebody says, okay, patient, ACPC 20/20, 50% and 5 a PEEP. Well, what do they mean by that? So we're just going to break down and see, well, what do all those acronyms and numbers mean when someone throws vent settings at us? So for this one, think through for a sec what that might mean, and then I'll flip the slide. So ACPC 20/20, 50% and 5 a PEEP. What that means, it's just the AC and the PC, that's going to be assist control and pressure control. So assist control with a rate of 20 and pressure controlled to a pressure of 20. So we're in a pressure mode of ventilation. So therefore the tidal volume is going to vary. It's going to vary from person to person and from breath to breath. The 50%, that's going to be our FiO2. So 50% oxygen, 50% FiO2, and 5 a PEEP. The next example, so if I said the patient's on AC 12, 500, 80%, 5 a PEEP. So what are we going to mean by that? So AC 12, assist control with a rate of 12. 500, so that tells me that it's volume ventilation. So a tidal volume of 500. So that's going to be 500 of air given, regardless of the pressure needed to obtain that. 80% FiO2, and then 5 of PEEP. Our last one, so a patient's on SIMV 10, 450, 100% and no PEEP. So what would we set our ventilator to? SIMV of 10, so synchronized intermittent mechanical ventilation at a rate of 10. 450, so that's going to be volume ventilation, a volume of 450. So regardless of how much pressure it takes, 450 mils is the volume. 100% would be 100% FiO2 and no PEEP. Now something that's missing from this one, there's a setting that's missing here. Remember, pressure support. I said these patients in SIMV are typically going to have pressure support. So we would also probably see a setting on here of PS10 or PS8, whatever that setting is. So pressure support of 10. And that's just to give us that little punch, that forward driving pressure for when they take a little breath on their own. Good. So let's talk about ventilator alarms. So the important thing to remember is if you have a vent that's alarming, regardless of the alarms, if you're not sure if the patient's being ventilated, just disconnect them off the vent and bag them with an ambu bag through their endotracheal tube. Sometimes the ventilator may be alarming and they're still being ventilated, no problem. But if you're not familiar and you're not comfortable reading that ventilator screen to see what's actually happening and to see if the patient's still being ventilated, then just take over ventilations with an ambu bag, troubleshoot the ventilator. All right, so common ventilator alarms, kind of four main categories of ventilator alarms that are the common ones. High pressure, low pressure or disconnect, apnea, and low tidal volume. So we'll look at each of those. So high pressure alarms. So high pressure alarms are when air is having trouble getting to the patient at the prescribed rate and volume. So it's trying to deliver the breath, but it's having trouble getting it. So this could be an obstructive problem or a compliance problem. So it could be there's something obstructing the actual tube or your ventilator circuit, or it could be a compliance problem. The patient's lungs are getting stiffer. It's getting harder to ventilate this patient. It can be caused by things like asthma, mucus plugs, tube obstructions, pneumothorax, worsening ARDS patients. That's where we would see the compliance decreasing. That's where we may see high pressure alarms. Low pressure or disconnect alarms. So that's when the ventilator senses low pressure. So that's typically going to be a loose connection or the ventilators become disconnected somewhere. So somewhere on that ventilator circuit. Something to remember with these patients is there's a lot of spots where you could have something disconnected. So think about if this patient has an endotracheal tube coming out of their mouth and connected to that, depending on our facility, we may have a end-tidal CO2 monitor, and then we may have a Ballard for suction, and then we may have a viral filter, and then we may have a elbow, and then we may have the ventilator circuit. So you're talking 5 extra connections hanging out this patient's mouth. So any one of those that were to come loose or fall off, we could get a low pressure or disconnect alarm. So checking all those connections. Apnea alarms, not something you're typically going to be getting because we're not going to have that on for a patient that is on a ventilator mode that's delivering the breaths. So apnea is going to be more for a patient that's on like pressure support ventilation when we're weaning them off of the ventilator, like we talked about earlier, where we're expecting them to be breathing on their own, then we would want to know that they've went apneic. So it's not needed in patients, that are on full ventilatory support. And then low tidal volume alarms. So the patient's receiving lower than normal tidal volume, regardless of the effort of the ventilator. So this could be, cuff leaks, a patient biting at their tube. They could be coughing. Sometimes a kink can do this. So how do we troubleshoot them? So high pressure alarms. We want to look at, is the patient biting their tube or do they need suctioning? A good test for that is, can you pass the suction catheter down the endotracheal tube? If we can, then that tube is not obstructed, right? And then we can suction them on the way out and see if that helps clear the problem. One of the common high pressure alarms is, am I leaning against the bed and I'm crushing the ventilator tubing against the rail? Been there, done that, you'll get a high pressure alarm. Same with if you put your foot on the tubing in the back of an ambulance, you're gonna get high pressure alarms for those. So just look for a kink in your circuit. Low pressure or disconnect alarms. So first thing we want to check is the ventilator still attached to the patient's airway. And like I said, if we've got 5 connections hanging out the end of their mouth, are all those connections tight? And is there any piece of the ventilator circuit that's disconnected? Depending on the model of the ventilator that we're using, there's a lot of attachments for the ventilator circuit. Sometimes there's 4 attachments for a ventilator circuit onto the side of the ventilator. So are they all attached or are any of them loose? Apnea. So if this was a patient where this was a concern for us, we'd want to know, were they expected to be triggering breaths? Have their condition deteriorated, or did they just receive, a sedation or paralysis? Hopefully not if we were weaning them off a ventilator, but you never know. Low tidal volumes. We want to know, is the patient coughing? Is there a cuff leak? Are they biting at their tube? So maybe they need additional sedation. We'd want to assess the patient. When you run into problems, when problems arise with this, we want to remember SAT problems. So if you're managing this patient and your oxygen saturation is the problem, so we have a low SAT, the setting changes that we would make on a ventilator are FiO2 and PEEP. So FiO2, because that's the amount of oxygen that we're giving the patient, so the availability of oxygen, hopefully, and then PEEP. That's going to give us more surface area for gas exchange to take place. Those are the two settings that are going to affect your SpO2. You could play with your rate and your tidal volume all you want. It's not going to fix a saturation problem. Saturation is how much oxygen are we giving the patient and how much PEEP do we have, so how much surface area do we have for that gas exchange to take place. Thing to keep in mind, SpO2, I like to explain it kind of as your rear view mirror in your car. SpO2 is what happened, a minute ago. It's not an instant reading, right? It takes a minute for it to catch up when we make an intervention, so give it a few seconds. Especially in a sick ARDS patient, we might have to get that FiO2 up and that PEEP up, and it's going to take a while for that SAT to get up there because it's taken a while to recruit those alveoli. End-tidal CO2, on the other hand, that's reflective of ventilation, right? SpO2 was oxygenation, end-tidal CO2 is ventilation. So it's going to respond to changes in your minute ventilation, your volume, and your rate. So end-tidal CO2 is all about rate and volume. So how much CO2 are we blowing off the patient every minute? So how much minute ventilation are we putting through them? You could do whatever you wanted to your FiO2 and your PEEP. It's not going to fix an end-tidal CO2 problem. So those are kind of the hallmarks there. SAT problem, think FiO2 and PEEP. End-tidal CO2 problem, think volume, rate. Remember, you can be ventilating somebody perfectly, but not adequately perfusing them. You can be perfusing somebody perfectly, but not adequately ventilating them. If all else fails, you're getting alarms, you're not sure what's going on with it, take them off the vent, bag the patient, and then troubleshoot the ventilator. And remember, in a pandemic, there's not an emergency. So if something happens, you have a ventilator alarming, we're still going to wear our PPE before we go in and address that ventilator. They can go without the breath for a couple breaths off the vent while we get our PPE on and get in there, okay? Some vent changes as far as ARDS go. So when we're looking at ARDS patients, to kind of recap what vent changes we would see there, they're going to have high levels of PEEP potentially. So you're going to see much higher than normal normally. Like I said, you may see numbers up 14, 16, 18, 20 a PEEP on some of these patients, especially the real difficult hypoxic patients. You're going to have high FiO2 levels potentially. They may be on, a high level of PEEP with 100% FiO2 and they're still not oxygenating. We're going to monitor their plateau pressures in ARDS patients, and I'm going to talk about that in a minute. We're also going to monitor their driving pressure. There may be protocols. If you're managing these patients, you may have a protocol to follow which tells you to adjust their tidal volume based on their plateau pressure and their driving pressure. We'll talk about those in a minute. And in lung protective ventilation strategies, remember we're using lower tidal volumes than we might be used to. Like I said earlier, we want to maintain our PEEP when we disconnect, if at all possible, if they're a very sick ARDS patient that has a recruitment problem. The majority of patients, we don't need to be clamping tubes when we change devices and that sort of thing. But if they're really a troubled recruitment issue and they're hard to, poor oxygenation was hard to get that recruitment, hard to get their SATs up, then maintaining the PEEP when we disconnect is always a good idea. So let's talk about those couple of pressures that I've mentioned. So first, we're going to talk about what a PIP is, a peak inspiratory pressure. All that is the maximum amount of pressure that we apply to the patient. So in volume ventilation, we have a peak inspiratory pressure. We don't have one in pressure-controlled ventilation because we set the amount of pressure. If we have someone on pressure-controlled ventilation and we say a pressure of 22, their PIP is 22 because we set it. But in volume ventilation, if I say give them 500 cc's of air, it's going to give them 500 cc's of air, and maybe it takes 25 of pressure. That's their PIP, that peak inspiratory pressure that it took. The ventilator is going to tell you what it is. Every breath, it's going to show you what their PIP is, and it's going to tell you what it is. Typically, we want to see that below 35 if at all possible. And that's reflective of the work to overcome the resistance in the airways and to distend the lungs and the chest wall. So it's kind of resistance and compliance. It's getting the air into the patient, right? So overcoming the resistance of the circuit and getting those lungs inflated. So you can see on this graph here, it's just the top pressure that we see onto the lungs right here, your peak inspiratory pressure, as opposed to a plateau pressure. A plateau pressure is measuring the pressure kind of that's hitting the alveolar level. So arguably that's going to be more important than your PIP in a lot of patients. We want to keep it below 30 to help prevent ventilator-induced lung injuries because we don't want to cause more damage with the pressures we're applying to the lungs. It's lung protective ventilation. We measure it by doing what's called an inspiratory pause. So in high plateau pressures can cause volutrauma secondary to over-distending the alveoli. So we don't want to cause that more damage to those sensitive alveoli. So how do we do an inspiratory pause on a patient? What do I mean by that? Well, all we do is have the patient hold their breath while they're on a ventilator. Well, we can't tell a patient to hold their breath while they're on a ventilator, so we have a button on the vent that will do that for us. So it is an inspiratory hold button or a plateau pressure button on the ventilator. And what that does is it just breathes in and then holds their breath. So you can see on this second part of the waveform here, there's an inspiratory hold. So what happens is the lung gets inflated, we hit our PIP, which is the top here, and then they hold their breath. And just like if I were to blow up a balloon, it's harder for me to get the air into the balloon than to just hold the air in the balloon. So that's why we have this plateau that happens. We get our PIP, and then the number will come down and kind of even out. And that's our plateau pressure. So that's the number we look at, because that's the pressure that's truly hitting those alveoli. And we want that plateau pressure to be less than 30. So again, like I was talking about, you may end up with a protocol that tells you what's their plateau pressure. Is it above 30? Then it's going to have you do things like maybe decrease their tidal volume a little bit and see if that fixes the problem. The last pressure is the driving pressure, and you hear this one when we talk about sick ARDS patients. In the driving pressure, there's fancy ways on a ventilator to get this number. The easiest way to do it at the bedside is all you're doing is looking at the pressure from the difference between your plateau pressure that we just talked about and their PEEP. So if we got a plateau pressure of 29 and I had them set to 18 of PEEP, 29 minus 18 would give me 11. That means my driving pressure is 11. So think about it, the way that I kind of remember it is that's what's driving those alveoli open. So it's my plateau pressure minus my PEEP. That's my driving pressure, or my kind of opening pressure for those alveoli, right? So our driving pressure is another number that may be in a protocol that you would look at, where it would say, if their plateau pressure is, more than 30 and their driving pressure is more than 15, then do whatever, decrease their tidal volume by 1 cc per kilogram or whatnot. So these are just some of the numbers you might see if you had to follow a protocol, but they're typically self-explanatory. It's just understanding what the numbers mean, because then you can follow the protocol. That's kind of vent settings in a nutshell. What we're going to do now is look at what are the ventilators that you could end up with in a pandemic. So it's nice when we have ICU multimodality ventilators in a hospital, but the reality is if we have, patients that are exceeding the resources that we have, we're going to be getting different various types of ventilators. I'm going to show you 3 that are in the strategic national stockpile. You may see other ventilators. If this were to get really bad, you may be getting ventilators from wherever they can be sourced from. Right now, you hear about Dyson and Tesla and all these companies making ventilators, which is great, but they just might not be something that you've seen before or you're going to see on this. But I'm going to go through the 3 that are in the strategic national stockpile, which could be dispatched to different areas of the country. The first one is the LP10 from Medtronics. So this ventilator can do assist control volume, and it can do SIMV volume, and it has something called with pressure limit. So what this means is all it is volume ventilation on this vent. It cannot do pressure modes of ventilation. Well, what did we say is nice sometimes in sick lung ARDS patients? Pressure modes of ventilation, right? So unfortunately, these ones can't do it. But they do have a pressure limit on them. So you can set the maximum amount of pressure. So you could set them to be assist control, 12 breaths a minute, 400 cc's of breath, but you can set a pressure limit where it will cut the breath off if they hit a certain pressure, but it's still volume ventilation. Important thing to know with this ventilator is there's no internal PEEP on it. So what did we say these sick ARDS patients need? They need PEEP, right? Fortunately, this vent doesn't have it. But we can still do it. What we do is just like on an ambu bag where we want to give PEEP with an ambu bag, we put a PEEP valve on it, right? That's just a little valve that we dial up how much PEEP we want, and we stick it on that spot on the ambu bag. Well, these ventilators, we would stick a PEEP valve on the exhalation circuit. There's a spot for it. There's instructions in the box. If you get one from the strategic stockpile, it shows you where to put that PEEP valve. And then you would dial the PEEP on that. So it's not a setting on the ventilator. Instead, it's the piece of plastic that we're putting on. You'll see this little note I have on the bottom of the slide. Document will be sent with your CEU. We have the basic user manuals for these ventilators, and I'm going to send a PDF out with the CEUs for the class today on the different vents for the off chance that, you know, we are kind of overwhelmed as a country and you get some of these ventilators and you have to do it and set it up, then you'll have the kind of instructions for it. So that'll all be sent out with your CEUs later this week. This is what the front of that ventilator looks like. Pretty easy to set up if we needed to actually set up settings on it. First, you're going to dial what mode you want. So let's say we're going to do SIMV. You would just dial SIMV right here. Let me see if I can draw on it. No, that didn't work. Okay, so right here you would do SIMV. Then you have your volume. We would just set the volume. This volume is per breath. So it's in decimals. So 0.4 would be 400 cc's per breath. So we just dial whatever breath we want. The next one is going to be our breath rate. So how many breaths per minute? You can see it goes from 1 to 38. The next is their inspiratory time, how many seconds. That just means how long for the inhalation. Typically 0.9 of a second or 1.0 of a second is going to be fine for an inspiration time. As a starting point, at least 1 second is going to be fine to use as a starting point for you. And then it has your alarm limits above it. The next ventilator in the Strategic National Stockpile is the Univent Eagle 754. So this ventilator can do assist control volume and SIMV volume. It can also do CPAP. The nice thing with this one is it has PEEP built into it, so it can go from 0 to 20 of PEEP. So this one can do PEEP, but it's still not doing pressure modes of ventilation for us. What it looks like on the front, if we had to set it up in a pinch, and I will also send out, we have the basic instruction manual for this as well. It'll come with your CEs. Again, breath rate down here, your inspiration time, your tidal volume, and then your FiO2 over here, and then your mode of ventilation down here. So these are very much dial and go ventilators. You just dial what you want on them. They're fairly easy to use from a user standpoint as far as how to actually set them up. They're a more basic transport ventilator. They're not the big vents that you would see in the ICU. The last one in the strategic stockpile is the LTV 1200. This one is more of a multimodality ICU type ventilator. It's arguably going to be the most sophisticated of the three in the stockpile, and it can do assist control with volume or pressure. So this one can do pressure modes of ventilation. It can do SIMV with volume or pressure. It can do pressure support, so we can do SIMV with pressure support, so that patient doesn't feel air hungry. It can do CPAP, it can do NIPPV, or so BiPAP, and it can do PEEP, 0 to 20 of PEEP. What it would look like on the user screen for it looks a little more complicated to set up, but it's actually pretty straightforward and easy. Turns on with the power button down here. And then all the settings, we just press the button, turn the dial, and then press the button again to confirm it. So if I wanted 12 breaths a minute, I would press breath rate, turn it to 12, press breath rate again. Click on tidal volume, turn it to the tidal volume I want, click it again. All the buttons work just like that on this ventilator. And down here is where we could select between volume or pressure. If we were to switch to a pressure mode of ventilation, tidal volume will dim down, pressure control would light up. It's a pretty easy to use ventilator once you get the hang of it, but it's just a press, dial, press is how that one works. Again, I'll send out a user manual for this one with your CEUs. And if the ventilators come from that strategic national stockpile, they come in a box with instructions and stuff and the pieces that you need in them as well. With that, that will conclude our ventilator portion, and I am going to pass over to Jen for the next part of our lecture for talking about critical care for the COVID patients and a case study. So give us a half a sec here. I'm going to switch her to the presenter.
And can you hear me okay?
Loud and clear.
Okay, so there's a question in the chat if you want to look at that while I pull up mine.
Sure. If I can find my mouse on the screen, there we go, we're in business. So VBG versus an ABG. Typically, when we're looking at an ARDS patient, they're going to be getting arterial gases on the patient. These patients need arterial blood gases. Venous blood gas isn't going to help us direct the care nearly as well as an arterial gas will. Hopefully, in a perfect world, right, these are going to go to the ICU. Pretty much every patient that's going to be, an ARDS patient in the ICU is going to have an ART line in it. They'll have a central line ideally as well. So hopefully they can just be pulling gases from the arterial line in a perfect world. If not, though, just a traditional stick for a arterial blood gas is going to be the best when we really want to determine that level of ARDS, when we look at the PaO2 FiO2 ratio, because that's going to give us the best representation of how they're oxygenating.
Sorry, I'm just trying to be able to see everything I need to see.
No problem. I'm just checking if there's other questions. Sorry, I'm looking at 3 panels
Yep.
at once here. As far as, there's a question on there about when will these non-ventilator companies release their user manuals? I cannot answer that question. I don't know if they're building their own vents, if they're using models of other vents they're just manufacturing. I don't think anything's really out there yet for us to know much on that. When using an inline suction Ballard, do you advance until you meet resistance? Yeah, same as you would with a, if you weren't using a Ballard with a traditional suction catheter. It's the same thing. It's just in a protective sleeve, basically. All right, and with that, I will pass over to Jen. It looks like your slide deck is up, Jen.
Oh, good. So you can see it?
Yep.
Okay. So I can't see me, so I hope you can all see my slideshow. So I just want to thank Tobin real quick. That was a great overview of all the ventilator modes, all the various features that they have. I encourage you to go back to work sometime this week and go look at a ventilator that you have in your unit right now and take a look at those settings and talk to your respiratory therapist. That will give you, a sense of pulling this all together, this information, so that you can use it when you may need it. Also, ask your respiratory therapist in your hospital if they know what kind of ventilator they might be getting. I'm in the Sacramento area and I talked to my RTs. We're going to be getting the Vortran. We already have that in storage, and then whatever else comes from the stockpile. So you might be able to find out what's coming and get ready for that. Okay, so we're going to go over a little bit broader view of COVID-19, what we've learned so far from some journal articles that have already been published, and also just physicians across the country sharing information. Oh, good, you can hear me. Thank you. Okay, so first off, and you probably know a lot of these symptoms, our common initial signs and symptoms are fever, that's really the primary one, fatigue, chills, headache, nasal congestion, sore throat. They can have a productive or a non-productive cough. They may have some nausea, vomiting. We've seen diarrhea with some of our patients, and myalgias. Some of the unusual presentations, and also loss of sense of smell. And then some of the unusual presentations include syncope and seizures, and I've actually found some more information on neuro that I'll cover a little bit further in the slides here. So as we go through my slide deck, you'll see all the links that I have referenced, and then Tobin will be sending you a page with all of those links at the end when you get your CE forms. You'll be able to read those again in more detail if you'd like. So what I found interesting on this first slide is that people who have the comorbidities that make it a little bit, more likely to have mortality from this is diabetes, respiratory issues, including COPD and asthma, and chronic kidney disease. So it was interesting to note this is a very small, it wasn't a study, it was just an observation of these patients. So 3 patients with mild asthma had received systemic glucocorticoids within 1 week before ICU admission as outpatients for presumed asthma exacerbation when they had symptoms of COVID-19. The 3 patients then presented to the hospital again with severe respiratory failure requiring invasive mechanical ventilation. So previous studies have shown that glucocorticoid treatment for SARS, which is a similar virus, was associated with higher subsequent plasma viral load, longer duration of viremia, and worse clinical outcomes. However, in a randomized trial, they did not find this to be so. So right now, we really don't know if something like a prednisone or other steroids that we give for asthma is going to be helpful for this disease or not. So all the doctors are kind of taking that in mind when they prescribe the medications. Okay, So diagnostics, so this is for all of you ER nurses out there. What are you gonna expect in the way of orders when you first get your patient? So the COVID PCR test, your swab, and then most likely a respiratory panel to see if there's any other viruses that the person has on top of it as well. Procalcitonin, it says it's not usually increased, at least initially. If it's elevated, it may indicate alternate diagnosis or superimposed bacterial infection, but it can help further down the road. So if the patient has been admitted, the clinical course can be followed a little bit better with that. Also with CRP and sometimes the ESR2, sometimes it's difficult because it says it's performed manually, but it has been elevated, they've noted, in COVID-19 patients, and it seems to trend upward with progression of the disease. The other labs you'll probably see are liver enzymes, so the LDH, ferritin. Also, blood cultures are going to be really important in case you do have a superimposed bacterial infection. The lactate, troponins, CK, CKMB. They're also finding a lot of cardiac issues with this particular virus. An ABG, just like Tobin had mentioned earlier, will give you a good picture of your respiratory status. Chest x-ray, and then they can do a CT chest or a VQ scan. Either can give them good information. And then an EKG, it's nice to get a foundation EKG in these patients, as we'll see in a few minutes with the cardiac. So what they found so far, and some of these slides I've just updated this morning, there's been new information coming out literally every day, which is great for all of us to learn from. So poor prognostic factors, a neutrophil to lymphocyte ratio greater than 3.13, an absolute lymphocyte count less than 0.8, LDH that's greater than 245, ferritin greater than 300, CRP greater than 100, or D-dimer greater than 1,000. And that was put out just in the last few days by the Lancet Journal. So peds considerations, if you've got kids that are coming in, my particular ER, we're seeing a lot fewer kids because they're not at school and they're not getting sick from each other. But certainly there's kids out there, you know, getting some exercise, having asthma exacerbations. So, and they're certainly exposed to the virus. So far, we're not seeing them get that sick. The top 3 things that I have listed there is from our pediatric emergency chief. So he found that they appear to be high volume shedders. So that's important when you're talking to parents who, you know, have babies. If you look at number 3, they secrete it in their stool for up to 4 weeks. So make sure you're talking to parents about good hand washing after diaper changes. And then their smaller airways mean that the aerosol lands above the alveoli. So they're going to get an upper respiratory problem much more so than a pneumonia that's deeper in the lungs like we see with adults. And then from the American College of Emergency Physicians in the pediatric section, a significant proportion of pediatric patients appear to be asymptomatic, which is, again, what we're seeing with some adults. The white count doesn't necessarily get elevated, but they can look at CRP, procalcitonin, and liver enzymes. Most commonly in the kids, we're seeing fever and cough, along with diarrhea, fatigue, stuffy nose, nasal congestion, vomiting, and tachypnea and hypoxia in the most severe cases. So there's a link there called don'tforgetthebubbles.com. It's a really nice pediatric site, and they've got a specific section for COVID right now. So the disease progression that they've typically found in adults, so day 5 on average is when we start to get some symptoms. And like it says there, 2 to 11 days can be the range on exposure before we actually see symptoms. Day 5 is the increased shortness of breath, bilateral viral pneumonia from direct viral damage to the lungs. Day 10 is that cytokine storm that leads to ARDS and multi-organ failure. So Tobin and I talking about ARDS because that's really what they're seeing with this disease. And that cytokine storm brings all those inflammatory mediators into the lungs and creates a very specific way that we need to treat them with the ventilator. 81% have mild symptoms, which is the good news, but 14% have severe symptoms requiring hospitalization, 5% are critical. If they're admitted to the ICU, it's about 2 weeks on the ventilator, and the patient presentation is varied, as you've probably seen. China is reporting 15% cardiac involvement, which I'll talk about in a minute here. But I did see some data just earlier today that out of all the patients that do end up on a ventilator, about 1/3 of them do get better and come off the ventilator and are able to get better and go home. So that's the good news that we're starting to hear as we learn how to treat this illness. So if you can see my pointer arrow here in section A, that's an X-ray of a patient with COVID-19, and then panel B is only 24 hours later. You can see how much infiltrate is in that lung. And then slides here, C, D, and E. These are a CT, and this is that ground glass appearance that they're talking about, if you've heard them talk about that. So just a picture for you there. Okay, so the cardiac damage, this is really interesting. So there's two ways that they think that this virus affects the heart, either from the associated cytokine storm that is manifested by these elevated levels of all these cytokines, or myocardial dysfunction from direct effect of the virus on the heart. And so it's found that these patients are going to require vasopressors. If they had an echocardiogram, they didn't see a lot of myocardial dysfunction, but it seems to affect the heart very directly. So on this page, and like I said, you're going to get these links so you can check them out later. If you click on this YouTube video here, this is a lecture, or actually a whole conference on cardiac out of University of Maryland. And if you scroll, it's a 4.5 hour cardiac conference. But if you scroll to hour 4 and watch the half-hour lecture right there, the guy talks about how COVID affects the heart, and it's pretty fascinating. You can also click on the second link here that says UM-Maryland lectures, and you can download all of their lectures. And what I've done for you here is just take the most important things and put them in 2 slides for you. So what does COVID-19 do to the heart? So the recent reports from China and Italy, critically ill patients would sometimes show improvement in pulmonary function, but around days 7 to 10, they would actually decompensate, and they found it due to cardiac failure. And then the New England Journal of Medicine, this is back in 2018 with influenza B and A. They had a 6-fold increase in AMI in the first 7 days after diagnosis of the flu. So they think that the process here is that viral infections create that systemic inflammatory response. The inflammation leads to plaque instability, plaque rupture, and then a type 1 AMI, or myocardial infarction. Very interesting, if you look at this Lancet Journal article, it said little attention has been paid to cardiovascular burden of events, being pneumonias. Cardiovascular events typically follow flu symptoms about 7 to 10 days later and can be a significant cause of mortality. So it's something that we don't always recognize because we're so focused on other aspects of their disease. So again here, the sympathetic stimulation causes increased myocardial oxygen demand. So we're super focused on that with our ventilator, but it can cause direct myocyte injury, myocarditis, and then lead to elevated troponins, ST elevation on your EKG. And so it's actually hard for them to figure out what's going on exactly. So it's good, again, like I said, to get that baseline EKG so that later down the road when they're in the ICU, they can maybe do another one when they're not sure what's going on and see if there's been some damage and then deal with that. Over here on the picture, you can see this is like a plaque, and once it becomes unstable with all that inflammatory mediators, it can actually break off and then cause that myocardial infarction. So our takeaway message for the ER nurse is that they're ordering the EKGs, troponins, BNP, and other cardiac tests to help determine that inpatient course of treatment. Okay, I know there's a lot of words on these slides. Again, you can click on the link to learn more, but I tried to pick out some of the top things because there was actually quite a lot on neuro today. So some places are seeing encephalopathy, ataxia, and trigeminal neuralgia. There was a presumptive case of encephalitis that was right here in the United States. There was a case in China of Guillain-Barré syndrome. And there was another study here. Out of 221 consecutive COVID patients, 11 of them developed acute ischemic stroke. So they're also seeing a lot of coagulopathies with this particular virus, and some patients you'll notice will be put on heparin drips. And then in the United States here, this Dr. Stevens, he is at Johns Hopkins, they're gonna start a whole multi-site study on the neuro aspects of COVID infections. Okay, liver changes. Again, there's a link down here so you can read more about that. They're finding a lot of liver injury in these patients, and they're not quite sure yet if it's because of the virus or, on here you'll notice, because of the number of drug-induced liver injury that is from all the medications we're giving them, including antibiotics, steroids, and antivirals. However, that's interesting up here, according to the investigators, both bile duct epithelial cells and liver cells that express angiotensin-converting enzyme, which is now considered an entry receptor for the virus, can cause some of the damage in the liver. So some interesting things there. So again, liver tests that you may be getting on your patient would be helpful later in their progression of their disease. So good to have that when we have them in the ER. And then kidneys, this is a quote from a physician just today, and I believe he's out of New York. And the quotes are coming out of these references down here. So he says, over and over, we're seeing people present in advanced acute kidney injury with creatinine levels of 6, 8, and 17, despite no previous chronic injury disease. So, and then also a high potassium level. So they're going right to dialysis. And if you've heard the words CRRT and hemodialysis floated around, the difference is that CRRT is a continuous form of dialysis, and therefore it doesn't cause as many issues with if the person is fluid overloaded or hypovolemic. They don't have as many changes with their blood pressure and heart rate and all those sort of things. It's a little bit gentler to do CRRT than to do hemodialysis, which lasts just a couple hours. So both of those things hopefully are done in the ICU. I'm hoping you're not seeing CRRT in your ER. You may see some hemodialysis though as part of their treatment if you have to hold them for a while. Okay, so we're going to go into our case study here. So this is based loosely on a patient that we've had in our department, and it follows a very similar course to what I'm hearing out there. So Mr. Jones is age 78. His weight is 100 kilograms. Complains of shortness of breath, cough, and fever. His heart rate is 140, temp is 39.2. Blood pressure is 100 over 60, respiratory rate 22, sats are 90% on room air. So he became febrile last night at his skilled nursing facility and woke up feeling acutely short of breath with a productive cough and still feverish. He's on ibuprofen, acetaminophen, ocusate sodium, and ipratropium albuterol. When you do the review of systems, he has crepitus and expiratory wheezes bilaterally, a productive cough, and a history of COPD. Neuro is normal, cardiac is normal, abdomen is normal, and skin is flushed. So for our exam, he has a cough and a patent airway. He has bilateral crepitus for breathing, decreased air entry due to shortness of breath, expiratory wheeze, and no pedal edema. For cardiac, he's tachy and febrile, and then his GCS is 15, but he feels very weak. So what orders do you anticipate first? Of course, we need to start with the appropriate PPE. So I know you're all advocating for the right PPE for yourselves and for your patients right now. So take your patient to the room, make sure that they're isolated. You'll probably get orders for the COVID swab, a respiratory panel, and flu swab. The labs you can anticipate are a CBC, chem panel, troponin, BNP, procalcitonin, and C-reactive protein, chest x-ray, and then either a CT or the VQ scan, and a respiratory treatment. Remember that respiratory treatment is aerosolizing, so you should be using the higher level of PPE. So for our case though, your labs are drawn, your chest x-ray is complete, you're attempting to take the patient to the VQ scan, but he comes very agitated. So they say they can't get it done, the patient comes back to the ER. So now our heart rate is 140, blood pressure is 100 over 62, and sats are 88%. So you go ahead and put on 2 liters of nasal cannula, and the RT starts the respiratory treatment. Okay, so it's been a little while, the RT comes out, tells you your treatment is done, but the patient seems confused. You go in the room, you find your patient taking off his cardiac leads and his nasal cannula. He wants to go home. So you help get him back into bed, get settled, and see if you can get him over to the VQ scan. The VQ scan says they're ready, so you go back in the room, but you find the patient is now standing on the side of the bed with his leads off and looking very unsteady. You help him back to bed again and replace his leads. Oh, why a VQ scan versus a CT scan? I think in our facility that we have the option of both pretty easily. Sometimes our CT scanner is taken up by stroke patients, and the CT scanner seems to be a little bit harder to clean. So it really gives you good results either way. Okay, so for our patient, we get him back to bed, replace the leads, but he's getting more agitated and confused about where he is and says he wants to go home. So what's next? So we really need to go back and think about our oxyhemoglobin dissociation curve. You may remember this from nursing school, you may use it more frequently, but I love this curve because it really gives you a picture of where your patient is at. So if you see here, if your PaO2, your SAT is 80 and you go over to here, your PaO2 is actually in the 40s, which is terrible. So if my patient was, 88%, he was up in here, and now suddenly he's down to 78%, he's dropped down this curve quite a bit. So this is something to really pay attention to when you're starting to get someone who's more and more confused, and you're thinking, gosh, they're kind of driving me nuts. Actually, it's probably hypoxia. okay? So we just need to keep that in mind for all of our patients. The request orders for MOR-02 and the Society of Critical Care Medicine, that's the abbreviation SCCM, they tell you to titrate, keep the SATs above 96%, and then go ahead and get an ABG so we can see exactly where that PaO2 is. Okay, so our results, our CBC, the white count is not elevated, so not very surprising because this is viral. Panel is normal, but his ABG, 7.25 for the pH, PaO2 is 40, CO2 is 50, and bicarb is 18. So a fairly typical respiratory acidosis, which is what you can expect for these patients initially. So you've got your patient on 6 liters, but now he's down to 75%, and he's getting more confused and agitated. So you go ahead and apply a non-rebreather and advocate for more respiratory intervention. So fortunately, you get your pulmonologist or your intensivist or your hospitalist, one of those at the bedside. The patient is now pulling off the mask and has become more short of breath. Your respiratory rate is 38, heart rate is 130, blood pressure is 98/60, and SATs are 68% when you can keep the mask on. So what next? So you've got some options. High flow 2 is one of the recommendations right now that we can start with. It's supposed to be less aerosolizing than a BiPAP. BiPAP is an option, but what are the risks? We're being told everywhere that BiPAP is very aerosolizing, and you really have to keep an eye on that patient to keep the mask on just right, and it's a little bit risky for everyone. So when you think about the risks of the BiPAP and how well the patient will be oxygenated with how many people need to use PPE, and then also what we're considering is the clinical course of this disease, they decompensate fairly quickly. We need to think about what's the next option after that. And so real quickly here, we are in ARDS for sure. So this is kind of a picture of what's happening. On the left side is your normal lung, right? And then on the right side, this is the acute phase, and it shows you that you've got edema fluid with protein. So remember, just like a colloid pressure, it's gonna pull fluid into the alveoli. You've got sloughing of the bronchial epithelium. You've got necrosis going on with cells, inactivated surfactant, so it can't keep that alveoli open anymore. Then you've got neutrophils, leukotrienes, oxidants, proteases, tumor neutrophils in here, or tumor necrosis factor. And then, let's see, all kinds of other things in here basically that are creating all that fluid that is what your patient is, not oxygenating through, like Tobin was saying earlier. You can be perfusing and not ventilating and vice versa. That's what's going on in this cell at this point. So considering the clinical risks and the expected course that this patient is going to go through, hopefully your facility and your physicians are going right to intubation. Make sure that you've got your RSI ready to use. There's different types of RSI just depending on what your physicians want to use, what you have available. Limit the use of doing any bagging on these patients because you're just aerosolizing things. So you can do that non-rebreather as long as you can and then get to the point where you're just going to go ahead and intubate. Make sure you've got the right PPE in this situation. And then if you've got the facilities, hopefully you've got a negative pressure room with an anteroom. Try to do a quick huddle to discuss the roles, limit the personnel in the room, and make sure you have all the supplies that you need. We're considering LMAs a lot more commonly now because it's easier to intubate and it does work well. And then this is a viral filter if you haven't seen one. This should be added to all the ventilator circuits at this point. So in terms of fluids, I just found this article today. It was breaking news. So if the patient is normotensive, they're saying not to give a fluid bolus. If they're hypotensive, consider a very small fluid bolus versus a pressor. And if they're hypoxic and normotensive and require oxygen, actually consider a dose of Lasix. And this really goes against what we've been taught about sepsis for so long. But when you've got all this fluid already in the lungs, you need to be very careful. So this one is saying, like, do not bolus for the lactate too high. Really take a look at all the components of your labs. Are LMAs as secure for proning as an ET tube? Definitely not. That is a fabulous question. It's good if you are going to be able to leave that patient in place, and if they go up to the unit, they may have to intubate them so that they can prone them. So that's a great question. It really is only secure in the moment, and maybe for a couple hours. So back to fluid, the WHO is recommending a fluid bolus only in patients if they're septic shocked. So if we do a good job on those blood cultures and we find out there's actually a bacterial, a bacterial disease process going on as well, then maybe we do the fluids. Shock at presentation is rare, and do not start maintenance fluids. So some good information there on fluids, something that the physicians really need to consider. And then potential medications that you might see. There are numerous antiviral agents, immunotherapies, and vaccines being developed. Probably we're not seeing any of that too much. These are some of the antivirals that are being talked about, at least. I don't know how much you're able to see these in your clinical practice yet. Interleukin-6 inhibitors may ameliorate severe damage to lung tissue that is caused by the cytokine release. Again, I'm not sure how much you're able to see that in your clinical practice. And then you've probably seen things about NSAIDs that's damaging, and people are seeing that in the patients that died. That's really anecdotal literature at this point. We're not finding that in some of the studies. However, it is nephrotoxic, and we're having that renal failure in some of these patients. So they're being cautious with that, okay? And then if pneumonia is suspected, because we're still rolling out like a community-acquired pneumonia, they're still considering ceftriaxone and azithromycin for those patients. They can give PO instead of giving a big fluid bolus if needed. And then always consider sepsis. So if we need early antibiotic administration, it's going to save that patient if they've got a superimposed pneumonia. And then avoid vancomycin because of the potential for renal failure. So this is the cart in my emergency department. I'm not advocating that you buy any type of product. Just say that as a disclaimer here. But on top, we have our bleach wipes, we have our gloves, and we have our clipboard of all the people that are going in and out of the room so we can keep track. Right here in the top drawer, we've got plastic bags. We're using those so that we can intubate the patient with kind of just that layer of plastic over them that minimizes the aerosolization, and then put that directly in our trash afterwards. In the next drawer down, you can see our viral filter right there. And then down here, we've got our PAPR devices and the hoods. And then in the bottom drawer, we've got our foot covers and our face shields and more of those plastic covers. So in this way, because we have very few PAPRs in our hospital right now, we're able to keep it all in one place, and everything gets cleaned off after and put back because that's all we've got right now. But consider having, one cart that you use for your ventilations. I know there's a lot of hospitals talking about like a specific code team or intubation team that's, they work well together because they're doing the same thing commonly or frequently throughout the hospital, and they also have all the supplies all together. Okay, so some other vent orders and considerations. So like we talked about, high flow nasal oxygen can be considered or to prevent intubation. Tidal volume, as Tobin talked about, should be small or lower amounts, but PEEP, there it is, it can be moderate to high levels. And then neuromuscular blockade, those are some of our medications that would help reduce the work of breathing. So you maybe have, a bolus of vecuronium. Hopefully you're not doing full-on drips because that does require a high level of observation for those patients. Prone positioning, I'll still talk about in a minute. Fluid management, like we talked about, actually a negative fluid balance. The renal replacement therapy. The recommendation to withhold fluid seems logical, except for it sounds like many present with renal injury. Are those patients still getting fluids? So it's really going to depend. I did read some articles from nephrologists saying that they're dialyzing patients off if the lungs are full. So you really, once they get into the ICU, they really need to have a pulmonologist and a nephrologist talking and figuring that out because it's a pretty delicate balance. So that's a great question. Renal replacement therapy. So looking at their electrolytes for sure, if they're still in your department. And then antibiotics can be with that superimposed bacterial infection. Yes, we'll get to sedatives in just a minute. And then glucocorticoids, like I mentioned way back at the beginning of the lecture, are not recommended at this time. Some places are moving to ECMO, but that is not common in a lot of hospitals. Certainly wouldn't want to start that in the ER if you don't have to. Okay, this one, okay, I know COVID recommendations are changing daily. I read this morning their concern of high levels of PEEP is causing lung damage. So yes, I've seen that as well. So what they can do when they get to the ICU or even in the ER, if you've got an RT that has some time, they can do a process called lung recruitment strategy. And I think Tobin actually talked about it earlier, where they give that breath and then they make the patient kind of hold the breath. and they see exactly what level of pressure they need and what level of tidal volume they need. And that will reduce how much PEEP you need if you can get that set just right. So it's a lung recruitment strategy. It's also called an open lung process. Thanks, the driving pressure. Yep. So that's something that your RTs, they're so valuable at doing that for you so that we can really do the right thing for the patient and decrease any potential lung damage. So great questions, you guys. The screen I have up now, so if you look up at the top, you've got mild ARDS, moderate to severe ARDS, and then rescue adjunctive therapy. So it just, you can maybe print this screen for yourself. It is at the Society of Intensive Care Medicine page, and then the Surviving Sepsis Campaign. So it just kind of talks about all the things I've mentioned so far. And then if you do need pressors, they're recommending norepinephrine, and for the inotrope, they're recommending dobutamine. Okay, so here's our proning. So the top picture here is what you would see in the ICU with that huge proning rotating bed, which requires a lot of people to get the patient into it. And then it requires, you know, at least the 1 to 2 nursing so that people are checking on all the pressure points, making sure the patient is stable hemodynamically and they can tolerate this. And what it does is it allows, obviously, the lungs to shift so that the fluid can move around in there and hopefully get not just drained, but released in some way. And so it's not just all sitting at the back of the lungs, you know, as they lay on their back. And also the heart, as a large organ, is laying on top of the lungs, creating a little bit of pressure. So as we're able to rotate those patients around, we're able to hopefully mobilize and move that fluid so that it can get out, okay? So the best we can do in the ER is this bottom picture. And if you notice, she's gonna have completely different pressure points. It's gonna take a number of people, if you do this in the ER, to turn her properly. And what you really wanna do, because I used to work ICU and we didn't have proning beds when I used to work there, is everyone is responsible for a line. So everyone's responsible for one IV line, someone is responsible for that ET tube, someone's responsible for the Foley, that sort of thing, so that nothing gets pulled out as you're trying to turn the patient. So if you look at her though, you gotta look at totally different pressure points, like I said. So you have to consider her nose, her ears, her shoulders, maybe her hip bones, and then her knees and her toes. And then you can even see the top part of her hands. All right, have a good night at work. Okay, and then as Kevin mentioned, your best results are actually 8 to 17 hours a day. So you can see that these patients really require quite a lot of attention so that they're not getting skin breakdown as you're trying to save their lungs. Okay, sedation, so here's your question. So yes, propofol is being used for sure, although I'm hearing in some parts of the country they're running out. So you need to think about what else you could use. Fentanyl Versed is a good combination, and then possibly paralytics, but again, you need to make sure that your normal air mattress would work with a prone patient. Yes, that would definitely be helpful. Yep. So back to this, so paralytics would be one way that you can keep your patient, again, to have that decreased work of breathing. Make sure that you're also giving a sedative and a pain control medicine if you're doing paralytics, and that you're cautious that you're moving your patients frequently so they don't get that skin breakdown, because they really are not going to be able to move, you know, when they're paralyzed. And then if you've heard of Precedex, this is commonly used in the ICUs under very controlled situations. Let's see, seeing ketamine for sedation. I personally haven't seen ketamine yet for sedation. We're mostly using it for pain control in my department at low doses, but I haven't seen that personally. Maybe some other people could type in and say if they've seen it. But back to Precedex, if you can see there, I listed all of the side effects of Precedex. So before you're giving this medication, if it's the first time you've ever seen it, you really need to take a look and see if you've got enough time to devote to that patient for all the potential things. So bradycardia is one of the problems with it. It also causes a lot of renal problems. So if they're possibly going to have, you know, kidney problems with the disease, that's not the appropriate medication. And then hypoxia, pulmonary congestion, and respiratory acidosis are already things that we're dealing with. Also blood pressure fluctuation. So this is really not a great drug for a patient on ARDS, but it may be something that your hospital has to go to because you've run out of the other medications. So I'm just throwing it out there as something so that you may have heard of it before you get to that point, but really be cautious with this drug. Okay, so we're close to the end here. This was a study done that shows how long the virus lives on various surfaces. So you can see cardboard, stainless steel, and plastic up to 24, 48 hours, even as long as 72 hours. This picture down here is kind of a nice pictorial of how long it lives on surfaces as well. And then I have wash your hands here and wash your hands here. And that is so that you'll remember to wash your hands on the way in and on the way out of your rooms. I know you do a good job on the way out. I'm the hand washing auditor in my department, but you got to do it on the way in as well. So these are some of the links that I will share with you that Tobin said when you get your CE forms. So I looked at this paper of critically ill patients in Seattle. This paper talked about the cardiac aspects. This is how long the virus stays on surfaces. This is about proning. This one also talks about cardiovascular. And then this is my personal article that's in the Journal of Emergency Nursing. It's called Caring for Critical Care Borders. And you can, if you're an ENA member, you can pull up that article and it gives you a lot more information about how to take care of a critical care patient if you have to hold them for up to 12 to 24 hours. So I'll let Tobin answer if we're going to send out the slides.
All right, 1 second here. Let me get the screen back open for everyone. All right, so we're going to send a packet of handouts out with the CEUs. So that will come with the CEUs later this week. There's a couple questions that had come up. I'm just looking at the list here. There was someone had asked about IE ratio with regards to ventilation. As far as what IE ratio is, I really didn't get into that in the vent lecture. What that is your fraction of the time you're spending inhaling versus exhaling. That comes more so into play when you're dealing with like an asthmatic patient. Normally when we're sitting here, let's say I have an IE ratio of 1 to 3. That would mean that it takes me 3 times as long to exhale as it does to inhale. So I would inhale for 1, exhale for 3. So when we talk about that breath cycle, if we said that we had a breath cycle that is 5 seconds long, let's say, so 12 breaths a minute, 5 seconds per breath. If my I time, you saw that inhalation time, the I time on the ventilators, if that was set at